Welcome everyone to today's webinar, Why Identity Governance is Critical for Clinicians. I'm Rebecca Sliz, Senior Product Marketing Manager at Imprivata, and I'll be the moderator for today's webinar. I'm excited to be here with my co-presenters, Dr. Sean Kelly, Chief Medical Officer at Imprivata, and Dr. Kathleen McGraw, Chief Nursing Information Officer at Microsoft. Some topics we may cover today together include things like risks to healthcare organizations that don't sufficiently verify access rights or ensure compliance. Also, increased provider satisfaction with day-one access to key clinical systems and data. And business case benefits with an automated identity governance solution. Our conversation is going to be Q&A style, so we also encourage you to submit your questions via the Q&A box at any time during the webinar. As we get into our conversation, I'd love to have our presenters introduce themselves. So starting with Dr. Kelly, please give us a little introduction.
Thanks, Rebecca, and hello, Kathleen, and thanks to all the rest of you joining us today. My name is Sean Kelly. I'm the Chief Medical Officer at Imprivata. I head up a clinical workflow specialist team full of practicing nurses and myself. And I am a practicing physician in emergency medicine at Beth Israel Deaconess Medical Center in Boston and Harvard Medical School. So I do have some direct experience with patient care and administration on the hospital side. So I'll be putting that hat on a little bit today. And I know that Kathleen is also a nurse. So I'll turn it over to her to let her introduce herself as well.
Thanks, Dr. Kelly. Thanks for having me. First off, I'm Kathleen McGraw. I'm Chief Nursing Information Officer at Microsoft. My background is as a trauma critical care nurse. I worked at the bedside in multiple specialty areas within trauma and critical care for about 25 to 30 years. I hate to date myself, and also am a nurse informatician. I work at Microsoft to help organizations work on digital transformation, and I'm very excited to be here and talking about this topic today because I think it's very important in these times.
Great, thank you both for joining us. We are here to talk about healthcare and how the healthcare ecosystem has gotten increasingly complex over time. Driving this need for digital identity. So, Sean, can you start off and walk us through some of your observations of how healthcare has become more complex and why that digital identity is at the center?
Absolutely. So, Kathleen, you remember the good old days? I don't know if they're all that good all the time, but certainly a little more simple back when we had sort of the four walls of the hospital. And a lot of our electronic work was done there on site, right? Like, and remember, I mean, I used to do paper charting a while back, and then finally that became digitalized and electronic. But oftentimes we were on these fat client desktops. We were in the hospital doing our work or in the office. And it was really the clinicians that were really on the digital platforms the most. It was primarily at hospitals or a few select office locations. You know, the breadth and depth of the access points wasn't so complex as it is now. And most of the time it was just like all the brains of the operation were right there on site in that kind of fat client desktop. And, you know, at that point, digital identity was a little bit simpler. You could have a firewall around it. When I logged in, you know, there was physical access control, logical access control, and, you know, the IT and the IS professionals could kind of wall that off. And that was really most of the workflows at a certain point. Things have now obviously gotten much more complex. So Rebecca, if you want to build out, yeah. So like, you know, now it's not just doctors and nurses that need to access systems digitally. It's really everyone. If you think about, and Kathleen, you'll appreciate this very much, but you know, the operations of medicine and the business of medicine and patient flow depends almost as much as or more on a lot of different roles, such as transport and technicians and radiology, mobile teams like PT, RT, OT, nutritionists, social workers, case managers. I mean, there's a ton of essential workers in healthcare. And not only do we all have multiple workers, but the truth is many of us have different roles on different days of the week or even at the same time. I mean, I myself was graduate medical education director, so my administrative access and complexity of what I needed to get into digitally compared to my job in the middle of the night as an ER doctor could be completely different. So there's complexity there now in the users and the roles. And not just that, but the locations. If you think about the enormous number of endpoints and the breadth of that now, you know, we're accessing systems from everywhere, whether it's from home, from, you know, doing telehealth, whether it's from the office, from an urgent care center, you know, just out there in the world on our mobile phones. And we're doing our work digitally from so many places in so many ways on so many different devices now. So, you know, mobile and the role of tablets and smartphones, that has expanded incredibly. And, you know, I can tell you that, you know, we don't go anywhere without our devices, and we oftentimes access medical records and plenty of other apps from those devices. So this is all getting more and more complex, and I need to access more and more things. And I'm sure, Kathleen, that you do as well. You see this value prop extending, but also the complexity is extending. And so really what is at the center of all of that, since you can't put a firewall around anything, is digital identity. If you can know who the users are and what devices they're using and trust that identity, you can open up access but still maintain security. So I'll just say that that's the common thread, and it is as important as ever to maintain digital identity.
I totally agree with you, Sean. The complexity over time, I think, has just grown exponential. I think one example is they say it's an average of 15 to 20 providers is taking care of one patient. So just the sheer number of folks that we have that are caring for our patients increases that complexity. Therefore, we need to understand the identity of each of these resources and how they're interacting with the patients. You know, the absolute ability to be able to have access to your patient's information anywhere at any time. You know, we call doctors, they're at her home, or, you know, they might be out to dinner or whatever. You know, nurse practitioners, physician assistants, I think it's all clinicians. So I like to include everyone. So we really need to have that ability, especially because we're more mobile and portable than ever. I think COVID is a good example of how we've kind of gotten there for many things, but the ability to be able to drive digital identity to each of these endpoints is going to be even more and more important as we move forward.
Right, and Kathleen, you just anticipated where we were going next, which is that if this ecosystem weren't complex enough, we had the disruption of COVID and many impacts that have occurred over the last several months. So help us understand a little bit how COVID has impacted these dimensions that we've just walked through: users, roles, locations, devices, applications.
Sure, absolutely, Rebecca. So I've actually been talking with customers, you know, since the onset of COVID in the probably February, March, April timeframe. You know, folks on the West Coast were impacted earlier, and it's kind of come across the country and then rolled back. So it's actually been for the past few months. We speak with customers every day around how they're utilizing technology to help their care providers and their other workers, right? How do we have our knowledge workers be more knowledge workers, our administrative personnel? Do they need to be remote versus being on site, as well as clinical support staff and even patients during the challenging times, especially around COVID? I think there's a common thread around these challenges, especially with COVID, is that we already had a very complex environment, and COVID just made it even more complex and a whole nother thing to think about within the aspect within that environment. And I think that many organizations, they're ramping up their clinical staff to maybe manage surges and support them. We're also seeing clinicians that are having to kind of help change their roles a bit to help support. or they may be moving from one area of the country to the next area of the country based on where the needs are. I've had customers that, have organizations across the country, and they've actually had to move their nurses to get support, or organizations, say in the New York metro area, where they had to bring in a lot of contingent staff very quickly. They had to get people onboarded, ramped up, and access to many systems so that they could continue to deliver the care to the patients. At the same time, more and more of the users are working remotely. So we had huge ramp-ups to organizations that had to have remote employees. And there's a question around how long will they stay remote, for what period of time, or if they'll even come back, actually. They needed secure access to their applications, to data. Essentially, these are folks that may be administrative as well as clinical. There's also the ability to set up non-traditional treatment centers, maybe in tents or field medical hospitals. I live in Baltimore, and we actually set up a field medical hospital, a mobile unit in our convention center here. And all of that still needs the information technology infrastructure to be able to support patient care, as well as the devices for which the users need access. It's changing as we move forward. Remember, we talked about mobile devices, both personal and corporate owned. Depending on organizations, they may supply a device, or they may ask people or their employees to utilize their own personal devices. And that's very much on the increase. We're also seeing hospitals, purchasing tablets, iPads, Surface devices, so that they can support telehealth as well as virtual patient visits. And finally, the applications that you're using, who has access to those applications has been very disruptive. So there's a need to quickly provide access to the various applications for clinical and non-clinical staff. So many of you are developing homegrown applications specifically in response to COVID, all of which need access management. And there are certain applications and workflows, such as EPCS, that require rethinking of existing processes. So we're hearing stories of how organizations have had to shift nursing staff, had to shift clinical staff, increasing number of contingency staff. So really, this puts the practice, the importance of data governance and the ability to be nimble and be able to respond quickly.
Yeah, and I'll echo a lot of those comments, starting in the kind of upper left with users and roles. As Kathleen mentioned, we're shifting workers back and forth. And in many cases, we were actually taking people that maybe had moved on from the ER or from ICUs, and they're working in other capacities and had different administrative permissions to access records and to perform duties and credentialing, and moving them back over to direct patient care responsibility in ICUs and floors and ERs. And as Kathleen said, sometimes we're even rotating staff into places like the Kravitz Center in New York, or the Nightingale Hospital in the NHS, and we're standing up these places in conference centers, and we even had one major customer in New York that was opened up a testing center and a community swimming pool facility. So you're standing up entire IT systems and all the access needed for them at the same time, and rotating staff around to those different areas. And so that becomes very challenging. And just to put my ER hat on for a moment, it doesn't do much good if you've got a system in place that guarantees access, but it takes 2 or 3 weeks to do that. We would have whole ICUs shut down because of exposure to a COVID patient. You had to rotate staff in today. Like, you have to have them ready on first day for proper access. And then there has to be good auditability to make sure what they're accessing and when they leave. So those needs are very real. They're really emergent. And so having a facile system that's scalable and automated becomes crucially important. And as Kathleen said, it's shown a bright light on some systems that a lot of us had already wanted to improve, but with COVID, it became all the more necessary. And, I'll also back up our comments around the remote workforce. I think most industries are going through that right now, where you really have to provide full capability for everyone to work remotely, like we're all doing right now. And so that's never more true than for clinicians that are providing virtual care over their own devices at home, or, like Kathleen said, through shared corporate devices that are managed by the healthcare delivery organization. In order to do that, and if you look even at devices, let's say, that are in the hospital, the onus shouldn't fall on charge nurses or a floor nurse or a technician to try to figure out how to provision and deprovision and charge up and get those devices ready. It's certainly really important to do all those things, but you really want everyone operating at the top of their license, as Kathleen said. You want nurses doing, I don't know, nursing? You want doctors doctoring, not monkeying around with technology and figuring out whether it's secure or not, or it's provisioned correctly. So there's good technology for that. We can talk about that a little bit. But again, it all hinges on proper identity and provisioning and deprovisioning of that identity. EPCS, or electronic prescribing a controlled substance, is near and dear to my heart. Since I'm in the ER, I'm on the front lines of the opioid epidemic. And I'll just put a plug in right now that the current COVID pandemic is only making the underlying opioid crisis worse. The isolation, the lack of care and therapy, and lack of resources available is actually worse for everybody suffering from opioid addiction. And so I'm just saying, like, electronic prescribing of controlled substances is actually more important than ever. Being able to complete the cycle of telehealth and actually prescribe controlled substances as well as non-controlled substance is a key component of telehealth and virtual care. So the ability to do that and to properly credential and have an auditable chain of trust and a log of all that that's DEA compliant has been one other essential piece of the puzzle here for digital identity. So that I would just put that in as another major app and functionality that's needed across the board. So echo Kathleen's comments, and I think we've dealt with, seeing how COVID, I guess the expression is, Kathleen, never waste a good crisis, right?
That's right.
This has been absolutely difficult as can be getting through COVID, but I've experienced a lot of tech teams and a lot of clinical informaticists actually being pretty pumped up because they're able to get some processes done in a matter of days or weeks that usually take months or even years. And now we're dealing with the effects of, how do we now make sure they're sustainable and they're really auditable and they work long term?
And speaking of long term, I will transition to a sort of trend view of what's been happening. You both just provided such rich detail about some of the impacts of COVID on some of those dimensions of the healthcare ecosystem. And that's why we're especially glad to have you sharing these experiences with us today. Taking a sort of higher view for just a moment, let's observe some of the trend lines, if you will, of how the COVID crisis has unfolded, and some other dimensions here in terms of what that's meant for care and virtual care and that remote workforce. So slightly different view of a couple things that we've been talking about. Kathleen, I wondered if you'd start us off with any observations from this view.
Sure. Thanks, Rebecca. So I think that as we can see as we follow the COVID-19 crisis line, right, there's a lot of dips and valleys. We see COVID is waxing and waning. We see that it's, across the U.S., we might see peaks in some states versus others. And, really, as you follow that line, you can see that we had this big spike in virtual care. And I would probably argue that the virtual care spikes, it may actually spike up a couple more times, right? As you have those COVID cases increase, you may see more virtual care within your organizations. But I do see that virtual care is going to continue. It may not be at the peak as, the millions of virtual visits that were happening. It'll come downward slope a little bit, but I think it will continue because it's been found to be a very valuable tool, and our patients are actually getting comfortable with it, as well as our providers. And then as you look at non-emergent care, obviously elective surgeries were essentially stopped. And now we're starting to see the uptake in non-emergent care and elective surgeries as patients get more comfortable coming back to organizations. We do still have organizations in the United States that are not able to start their elective cases, or they started them and then they've had to stop them. And we do realize that there is a whole mathematical model around restarting your elective cases. So if you've been without elective cases for 8 weeks, you're not going to make that up within the next 8 weeks, right? It's much longer, farther out than that. And that's a true burden on organizations, as well as the patients who are waiting to have some type of elective procedure. And then you can see the uptick in the remote workforce. And I think that will remain as an uptick. I'm talking to organizations every day that are giving me that they, information around, they're estimating that potentially 50% of their workforce may remain as remote workers, or they might give them more flexibility. So I think this is a new paradigm that organizations will need to adjust to and understand the needs for the remote and the mobile workers.
Yeah, and again, to echo Kathleen's sentiments, none of this is meant to be gospel or, and like she said, it varies from place to place, but we do see overall trends where virtual care is here to stay. I think remote workforce in many ways is here to stay. As we deal with the curve in COVID-19, one of the most interesting lines to me is the non-emergent care, as Kathleen said. I think early on, in order to deal with really ramping up and getting ready for the COVID-19 surge, most hospital systems across the U.S. took a huge hit in a lot of those procedures. Now they have a backlog to do, and they're trying to settle through those. There's really an appetite now to not let that happen again and to really try to plan for almost keeping parallel streams. Most major hospital systems I talk to do not want to shut down the other care. And that's good, both for financial reasons, but also for patient safety and care reasons. It was spooky sitting in the ER and realizing people were having heart attacks at home and, their cancer was getting worse and they were not coming in. They're getting septic at home because they're afraid of COVID and they're dying, or they're coming in with, their ejection fraction at 10% because all their heart muscle died because they had their heart attack at home. So we don't want that to happen now. So I think what that means is, with the added complexity, as we talked about before, the only way to deal with all these things at once is to actually have a good plan in place and to use technology to kind of help force amplify your effects. And that requires the good digital identity management that we had talked about before.
Mm-hmm. Mm-hmm. And that's also where we're going next. So we were talking a little bit at a both micro and macro level about these trends impacting healthcare and how digital identity is so important. So here we have a couple examples of ways that digital identities can be managed and secured in a healthcare environment. So, John, I wonder if you'd start us off on this slide, adding a little bit about these examples.
Yeah, I think we actually covered a lot of this when we're talking about the specific examples. And I think that, you just can't emphasize enough that it's a moving target. Like, every week it's different in the hospital. We're shutting down units and moving them around. We're turning COVID into non-COVID units. We were opening up resuscitation areas. We were opening up units that were, COVID treatment and COVID testing, and then closing them down and rotating them around. So all that requires the staffing changes that we were talking about, along with managing the identity to do that. That you need to maintain the secure access, but also the provisioning and almost as important, or maybe more, the deprovisioning, right? You have all this temporary staff rushing over and staffing an ICU, and then you have to cut off their access when they're gone to clean that up too. So, and then of course, at the end of all that, you want a good audit trail. So you need technology to do that. I don't know if you have anything to add, Kathleen. I know we talked about it already.
Yeah, I was just going to add one thing, because we've talked a lot about COVID, but we haven't really talked much about flu. But I think that we'll see similarly for flu, right? We're going to see organizations where they're maybe setting up an area that's segregated for flu shots for all their employees, right? Because they're going to mandate that they have flu shots, or the drive-throughs, drive-through testing, or, the testing in, like the fairgrounds, which is what they did in Maryland. They will remain open so that folks can not only get, testing for COVID, could also get their flu shot, so that we can continue to kind of, manage this crisis as we go forward and not exponentially run into issues with flu plus COVID.
That's a great point.
So moving on a little bit, I think the audience may be interested in understanding a little bit more about how Imprivata and Microsoft are working together to meet some of these digital identity challenges that existed pre-COVID and have been accelerated, if you will, or will continue to exist through COVID. So, Sean, I wonder if you want to start off on this slide talking a little bit about some of the components of an identity and access management system. So we see some of them here, including a single sign-on or multi-factor authentication, managing mobile devices, and of course in the center there, identity governance.
Sure. I mean, I think one of the things that I think most folks out there understand is that healthcare is a very unique environment. We're not tellers at a bank. We don't have very easy workflows where we all just go into our own office and sit in front of one terminal all day and do our work. Our digital working atmosphere oftentimes really depends largely on shared clinical workstations and fast user switching between users. I mean, in our ER, the nursing station computers are like hummingbird feeders where people are constantly buzzing up and getting on and off of them, right? And so every time that happens, you need to be able to quickly switch users, have everything be secure, and I have to be able to access what I need to access. And that includes the clinical systems like my medical record, my labs, my PAC system, maybe my dictation or whatever else. But it also might include all those other things like my Microsoft Office 365 suite, my email, my shared folders, Teams. And, I'll let Kathleen chat about that in a minute, but we've seen an explosion of use cases for many of these really healthcare-centric tools that are good for collaboration and care, coordination. So, traditionally there was a difficulty with that, and where Imprivata and Microsoft do so well together is customers used to have to choose between, do I optimize for jumping on and off of Epic or Cerner or my medical record on this shared clinical workstation, or can I optimize for what Dr. Kelly likes in his office? And here are all my folders, my email, here's all my stuff that I need to get to. Well, it turns out you can have both. If you do seamless SSO, where we do a run as feature, and so we see that identity at the front door, at the digital front door. As soon as I tap in as Sean Kelly, it knows Sean's here, and we can pass that to Kathleen and Microsoft and all their incredible treasure trove of everything in the cloud. So that transition of being able to now optimize so that when I sit down in a nursing station, I can get on and off of Epic really fast, or Cerner, or my own home-built EHR. But at the same time, I can now access everything in Azure that I need for Office 365, my Teams, and 3,000 plus other apps that I might need to. And there's a good architecture for all of that. And that's just the left side of this. I want to make sure Kathleen has a chance to weigh in on this, and then we'll cover a little bit of the rest of it.
Yeah, I agree. I'm working with a lot of organizations that use shared workstations, and I will say I'm going to have everybody kind of cringe on the call. I do actually work with organizations that are telling me they actually have generic logons, which I find is a little bit concerning and can introduce unwarranted risk. So really, I think the ability to have a shared workstation with a user log on that could be specific to them, and then they could have access to everything that they need. I agree. The electronic health record is of utmost importance, and the majority of the time the clinicians are going to be working in the electronic health record, but the ability to be able to do collaboration through other tools such as Team, through the ability to look at dashboards or other organizational tools that you may have to have access to, I think that is of utmost importance. So I think that regardless of who you are, having the ability to have your workstation kind of customized to what you want, kind of like how we have our own laptops, right? Things are a certain place and we know exactly where they are. I think that makes the workflow more beneficial to the end user, and it helps them be more efficient. And I think ultimately that's really what we're helping to do. We're trying to make it more streamlined, more seamless, so that they have access to everything that they need at that point when they log on.
So let's talk about the identity governance piece, because we think this is huge in healthcare, and this market, I think, needs to be disrupted. There are a ton of horizontal vendors who are trying to do for healthcare what they've done for retail and the financial industry, but it's just so different in healthcare. Like like I said, I still have multiple different roles, and my needs for each of those roles are different, from a security and compliance standpoint, from, an access standpoint. And so for all those reasons, the complexity of healthcare requires a healthcare specific playbook and solution. So our solution in Imprivata, working with Microsoft in Azure, can be delivered, and it offers an incredibly deep integration into the EHR, the HR systems, and Microsoft's messaging and Teams and all the other apps that we talked about. And just the integration into Epic's SER alone is incredibly valuable. The other thing is, you don't want some third party coming in and doing services to implement this and not understanding and not working with healthcare delivery organizations in partnership to really define the process of roles creation and maintenance. And the system needs to be scalable and automated so that, as we discussed before, people like me and Kathleen, when we hit the floors, have day one access. And so I think that the message here, and this is a busy slide, but the main point is deep integration into healthcare specific functionality is all the difference in the world. And then having a strategic partner who's able to work with a healthcare delivery organization rather than farming it out to some third party that does millions of dollars of services over several years for a partial integration. We have a very healthcare specific playbook. Both Microsoft and Imprivata are tailor-made for healthcare, and this solution is specifically made for healthcare. I can't stress that enough, that the needs are different, the demands are different, the workflows are different, and if you don't get the workflows right, it just doesn't work. So that's where we're at. We've created this healthcare-centric solution.
Yeah, I totally agree. I think that the ability to work with a partner like Imprivata is an honor for Microsoft because of your deep health knowledge. We do have a significant amount of health knowledge, and we'd like to bring that as well to the table. But I think we're better together, specifically for this.
Great, Kathleen. Thanks for that. And I think next we'll take a look at how identity governance has helped a healthcare organization. This is a specific use case that occurred shortly after COVID started. And Sean, I wonder if you would take the lead on this one and talk a little bit about how Virtua was able to use identity governance to provision access to an application for remote work and remote users.
Yeah, I think it's one thing to talk about a lot of these things in the abstract. I think it's really important to ground ourselves in real life examples. So, we talked about COVID hitting. Virtua was right in the middle of that first wave in the Northeast. And they quickly realized that they had to, quickly accelerate telehealth and messaging for, virtual care. And they needed to give access, proper credentialing and provisioning and access for users to deliver virtual care. And they happen to want to use Skype, and using our systems together, Imprivata identity governance with Microsoft, they managed to provision, these 400 users in less than an hour. And so we're talking about almost, near immediate provisioning. And, I can't stress enough what that means to me. If you're already asking me to walk into danger and see patients on the front lines and go to a place that I'm not even used to going to pitch in, to fill in for staff, and then do something different that I haven't done before, like telehealth, if I show up with all that and I don't have access and I need to call the help desk all the time and I have to borrow someone else's password, like, that's craziness. You can't do that to people. So this is just a real life example where, from a very pragmatic frontline standpoint, people realized, this is what the technology is for. They turned it on and it worked right away.
Awesome use case, Sean. It's a good one.
And Kathleen, perhaps you'd like to start us off talking about one other use case of identity governance, provisioning access to those clinical applications, critical clinical applications. And in this case, could be a staff ramp up, or as you both have talked about, clinicians changing roles during COVID, having to take on a new responsibility or work at a new facility or work in a different place. So feel free to share an example there.
Yeah, I've actually talked with customers that have moved staff, like nurses specifically, from one state to another, and the ability to be able to get them provisioned and ramped up very quickly was, really invaluable to them. And then they've actually moved them back, and they've had to, move the staff from where they went to help and, move them back. So they're kind of have this like flow of staff that they're able to really utilize. And because of the ability to be able to provision very quickly, the ability to be familiar with the systems, they've actually had a pretty seamless process. They've learned a lot, and they're taking these lessons learned and they're using it to manage the peaks and the valleys as they see them now with COVID. I think the other thing is that when you have new staff coming in to such, as Sean mentioned, this is a really high stress situation, especially for clinical providers. If you're bringing in contingency staff, I think at one point I heard one of my nursing informatics colleagues say that they brought in about 10,000 clinicians to the New York metro area to cover when they were at their peak in like the March and April timeframe. That's a lot of people that you're bringing in that, maybe have never been within your system before. And you really need to be able to provision them appropriately very quickly. You don't have time for, to wait days to get someone access to systems when we're really talking about critical patient care.
Yeah, and it's funny. So this is where healthcare is so different. Sometimes the devil's in the details too. So it's not just the provisioning, but also the approvals process, which normally could be a pretty complex process for bringing on a doctor versus a charge nurse versus a technician versus a lab worker or whatever. But when you decide as an administration that suddenly you've got 10,000 people coming in and, these 2,000 need to be provisioned on Epic or on whatever at this time for this thing, the ability to then route and create a system-wide kind of policy or, or a certain bucketed off policy in a certain area and say, hey, the approvals in this case are going to be streamlined in this manner, and that's the policy for a batch feed, a bulk feed here. It sounds simple, but not having that could make the difference of having a large percentage of people not actually activated in time. And so it's really knowing healthcare and thinking through these implications and then having the architecture that Microsoft and Imprivata have together that allows it just to happen on the spot.
And I think, Sean, in addition, these were contingency staff, or many were contingency and were there for a set period of time. So then you need to be able to deprovision as well, right? So that you have that ability to do it in a really timely manner and very, very streamlined process versus having this long, drawn-out process to deprovision these staff.
Right, with the safety features built in so that IS and IT are comfortable with this and compliance and legal in addition to the frontline staff. Correct.
So you both have given a lot of examples throughout our time today of why something like identity governance is really critical for clinicians. I wanted to start to close out with thoughts about how you interact with some of your other, or how clinicians and CMIOs, CNIOs interact with other C-suite folks in healthcare organizations, how you impress upon them how important identity governance is to you, that provisioning, also the deprovisioning. So I will perhaps ask Kathleen to start some comments around that, and also invite the audience, if you have any questions, now would be a good time to put them in the Q&A. We'll be getting to those next. So Kathleen?
So I think that the C-suite, CIO, CISO, obviously they want to make sure that all of their systems are of value to the end users, therefore can deliver effective patient care, and that they're secure and compliant. I think that we really are looking at how can our clinicians deliver care appropriately with the correct access at the right time for the right patient, all the rights of how you're trying to manage your patient, and that it's really important that we make sure that they can do it in a nimble, flexible way very quickly, so that they don't run into like these blockers. It's like anything, we don't want to impede any clinical workflows. We really need to be adjunctive to it, right, to really enhance them. That's how they're going to benefit. That's how our providers are really going to benefit from these electronic systems, as well as the patients.
Yeah, and like Kathleen said, I think it's about making the right thing to do, also the easy thing to do. And, I think you do have to satisfy all stakeholders. Like, no system works that's not compliant, that's not efficient for IT, but it also doesn't work if the clinicians at the end of the day can't access the right systems at the right time in the right place. And so, again, it's the partnership between us. It's the healthcare-centric playbook and knowledge, deep content knowledge, and then our close partnership with all of our customer healthcare delivery organizations that makes this happen. Like, no technology alone works without the process and the people parts around it. And so this is an iterative process. We work very closely with our hospital systems in concert with Microsoft to enable this and then maintain it. It's not hard, but it's complex, and the digital identity is right at the center of that.
Thanks, John, and thanks, Kathleen, very much. We are at the Q&A portion, and so again, I'll remind audience members, if you'd like to submit any, now is a good time. We have one or two that have come in, so I'll ask, we talked a little bit about how the healthcare environment has become more complex and the impact of COVID. What of those trends that we discussed a little bit, virtual care, remote workforce, are there any that we didn't discuss in this presentation? Any other trends that you're seeing or impacts that COVID is having that we didn't discuss that you think will affect healthcare organizations in the next, let's say, year or so? No one has a crystal ball. So other trends affecting healthcare.
I'll take this one. I'll go first, Sean.
Sure.
So I think that a big trend that we're going to see, we talked about virtual health, but we did not talk about devices and monitoring in patients' homes. And I think we'll see more of that, especially as we see maybe a more acute patient, instead of being in the hospital, they choose to be managed at home, or, if hospitals get overwhelmed again, as we see these dips and valleys, because I think we're going to see that for quite a while now. So I think we're going to see more and more devices, as well as patients will have their own personal devices, and they would like to have that data incorporated into their electronic health record so that they can be managed like a 360 view. That's one thing I can definitely think of as a trend that's coming on.
Yeah, it's interesting. I was going to answer along similar and complementary lines. I think it's about some of the virtual rounding or virtual care for patients, and coordination of that care both within the hospital and outside on that continuum of care in the borderless environment. I'll put a plug in for Microsoft Teams and other tools like it, where, we used to run, even before COVID, we used to have tumor boards where, patients with complex cancer cases would have to wait a month or two on clinician schedules most of the time to get everyone together and try to talk about, well, is this radiation oncology after chemo with this surgery, and who manages this along with the orthopedic specialists and so on and so forth. Like, what a great case to just put everyone on a collaborative tool and do it quickly. And so, even rounding or just, having a consult in the hospital, we could do this better, and we can capitalize on some of the lessons we've learned, both from a technology and a process standpoint, where why not involve the family members on a virtual platform to participate in that consult and to actually hear directly from that consultant? Why not actually have several clinicians on at the same time to allow for a team approach to care? I mean, that's what we should be doing anyhow. And COVID in many ways forced us to do this, because we don't want to don and doff PPE. We don't want to, bring on further infection control risks for each other or our patients. We want to limit visitation in a way. That was all necessity, but we can incorporate the better aspects of that into care when we no longer have to be quite so strict around some of those same policies. So I see it similar to you, Kathleen. I originally thought of this more in my world, which is in the ER and the inpatient, but absolutely in the outpatient world with the Internet of Things and connecting there. Again, digital identity is going to be key to all of that, along with delegated authority for parents to be able to look at kids' charts for, significant others, whether they're going to be allowed on or not, healthcare proxies and guarantors and things. So this is the new world. I think it's complex, but again, there's a huge value prop for getting it right.
So we have another question that's come in, and I will share it. It says, how does the Imprivata or Imprivata Microsoft solution address multi-factor authentication along with single sign-on? Sean, you may want to start with that one.
Yeah, sure. So I think we do this in a number of ways. We'd actually really like to host our own solution for two-factor in Azure, and we're working on that. We haven't completed that yet, but we do think that, particularly with our work around electronic prescribing of controlled substances, where we have a number of different really cool factors there, we think there's a large potential in healthcare for healthcare-specific solutions. With electronic prescribing of controlled substances, the DEA is very stringent around the compliance there. We actually have a Bluetooth, low energy, secure Bluetooth two-factor authentication that's completely hands-free and DEA compliant. And so that's one example of a great solution that right now isn't hosted in Azure, but we'd love to get there for everyone to be able to access through that manner. We just think that's the right way to deliver it to the market. And we just ran into some challenges there technically that we're working through with Microsoft that, we can't wait to get it out to market, but not quite available yet. We also think biometrics can be a big part of the solution, touchless and passwordless identity moving forward, and not just for clinicians, but for patients too. So Imprivata is the number one vendor for patient identification using a palm vein biometric, and now there's a touchless version of that as well. And we're exploring other biometrics that can be used and leveraged for not just two-factor, but for authentication in general. So stay tuned. There's a lot going on. FIDO, forgot to even mention FIDO. It gets a little over my technical pay grade, but there are a lot of incredible advances coming out. We're working in partnership with Microsoft on these, and we look forward to going to market together on them when available.
Kathleen, would you like to offer any other comments to close us out today?
I really appreciate that you had me in the discussion. It's always great to talk to a doctor, nurse to doctor, which is really exciting because I think that we really understand the workflow of organizations. And I think that's what's really important. We do need to understand that workflow. We've been there, we've lived it. We worked the night shift and the weekend, so we know exactly how organizations, employees are really trying to get by every day. So I think that's really important. So I just appreciate the time and thank you for having me.
Thank you very much for being here. And John, would you like to offer any closing comment?
Oh, I get last remarks, but I would like to thank Kathleen for coming because, as we all know, nurses do make the world go round, and it is the year of the nurse, Kathleen. So thank you for joining us. For real, it was great to talk with you as always, and appreciate your insights and perspectives.
Thank you both very much, and thank you to the audience for joining us today. Have a good rest of the day.
Bye-bye.